Now, I would like to request our second presenter, Dr. Shakibuzzaman Arifin, Associate Professor from Kidney Foundation, to present us about the management of AKI, peritoneal dialysis versus hemodialysis.
Assalamu alaikum, uh, honorable chairperson, respected audience. Now I am presenting today's topic: management of acute kidney injury, PD versus hemodialysis. So worldwide, PD accounts for 9% of all kidney replacement therapy and 11% of dialysis. And more than half of all patients receiving PD resides in only 4 countries in the world: China, USA, Mexico, and Thailand. And PD, unfortunately, PD used are 64 lower in low-income countries than in high-income countries. But PD has a number of distinct advantages that should be attractive to low-income countries like Bangladesh, India, Sri Lanka. That greater technical simplicity, lesser need for training staff and lower nurse to patient ratio, and greater feasibility in rural and remote communities, and fewer management challenges, especially during natural disaster, and greater cost effectiveness in some countries, and improved security of access in dialysis resource limited settings like Bangladesh, and somehow better survival in first few years. But there are some barriers also because of high PD fluid cost, lack of trained healthcare workers, and variable but often poor outcomes, particularly related to infections. So globally, PD peritonitis rate infections was decreasing day by day from 0.6 episode in 1992. Now in 2019 is 0.3 episode patient per year, and we are in high infection rate in Asia Pacific countries, and the lowest rate is reported in Africa, North, South, and the survival of PD has improved worldwide. For example, from 2009 to 2019, the US Renal Data System reported all-cause mortality decreases from 19.7 among with all patients with kidney failure. In case of renal transplant, is 10.5%, 17.5% in hemodialysis, and 21.3% in the patient receiving PD. All of we know the cardiovascular cause is the common cause of death in all patients of hemodialysis, all patients of dialysis. But in PD, the sudden cardiac death is 39.7, and in hemodialysis 44.2%. Already we know what is AKI, and this is also described. This affects 5 to 7% all hospital patient and 30% patient in ICU. Though the management is improved, but prognosis is still poor, and 40 to 80% death in ICU setting. So there are all of we know, two modalities are available worldwide, and PD is available from 1946 for AKI, for treating AKI, and introduction of CRRT in ICU leads to a rapid decline in the use of PD, despite there is no evidence of superiority of this modality in terms of outcome. So recent studies have demonstrated equivalent survival using PD compared with CRRT, and as a result, there is renewed interest in the use of PD in AKI for treating AKI, and it costs only approximately in Bangladeshi taka like 40,000, like 50,000. But all of we know a CRRT costs more than 1 lakh, and PD costs half that of hemofiltration. So PD is half of hemofiltration. And acute PD now largely is practiced in low and low middle income countries, especially in African countries. They are now using PD because lack of requirement of water and electricity, and significantly less training staff, and cardiovascular stability in hypotensive patient, most significantly the cost. So the International Society of Nephrology have added PD in their Young Saving Life program. They have added the PD, and 0 by 25 initiative for the API for the ISN program, and thus they have already saved more than 500 patient lives with PD in Saving Young Life program. And all of you know, during the COVID situation, what is the situation? There is lack of infrastructure, lack of staff, doctors, nurses. So PD have a special advantage in the COVID situation. So is PD a suitable modality for treating AKI? There are a number of advantages PD for treating AKI. However, there is long-held belief, including the doctor, is PD is unable to achieve adequate clearance to make it comparable with extracorporeal therapy. As a result, there have been concern that outcome may be suboptimal for treating patients with AKI. So recently published data of Cochrane review. This is already described in the previous lecture during the pediatrician. So they have proved its recovery, mortality, recovery of kidney function is moderate and low infectious rate in PD and correction of acidosis. Probably there is no a little difference and fluid removal and P by V may be higher with extracorporeal therapy. So PD they are equivalent to CRRT. So CRRT versus intermittent hemodialysis, like what we are doing, SLADE, PD has become variable modality, especially research support setting and during pandemic. So it's some useful thing. And CRRT has been compared with intermittent hemodialysis, that is SLADE. It is also equivocal with SLADE also. So what will be the access and fluid delivery for acute PD in adult? So flexible peritoneal catheter should be used where resource and expertise exists. So flexible catheter is preferable, and rigid catheter, that means what we are using in case of IPD, and improvised catheter, even nasogastric tube we may use where resources are not available to save the life of the patient, and ISPD recommend prophylactic antibiotic to prevent the PD related infection. So Tenkop catheter is preferable because it has a larger diameter, side holes, and resulting more flow and less obstruction and less chance of leakage, a low incidence of peritonitis. But for the saving of life, we can use improvised catheter also. Or is it, all of you know, rigid catheter have some complications, and we have a doubt about the percutaneous placement of PD catheter. So there have a number of studies, and also ISPD recommend that same outcome with percutaneously placed catheter and surgically placed catheter. So ISPD recommend that there is an expert available, we can do percutaneously placement of PD catheter. And there are a study, lots of studies that show the equivocal outcome with surgically placed. And so ISPD recommend prophylactic antibiotic during catheter insertion, but we have to cautious about the contamination of the catheter and the procedure of the catheter to prevent the infection. So what will be the solution we can use? Commercially prepared solution are available, and it should be used if patient can afford and if it is available, because it's sorry. And resource permit, and we also locally prepared solution can be we can also prepare locally solution from the normal saline, interlactate and Hartmann's. Just if we can add the glucose, 50% glucose, we can make it PD fluid when it's our purpose is to save the life of the patient. So potassium should be measured daily where the facilities are not available. We can add the potassium daily to maintain the potassium level. So commercially, solution are definitely better because they make high standards, strict asepsis, and careful monitoring of bacterial and endotoxin continuation. So there are a lot of studies also are doing now, especially in the Africa, and they have showed that equivocal about same outcome with the locally prepared solution from Bengal lactate and Hartmann's. So we can also do it in our rural and remote areas and also for the poor people to save the life of PD API patient. And KT by V is near about same and outcome is same with hemodialysis and filtration and CRRT. The weekly KT by V is near about same and same outcome. So what will be the recommendations of 24 to 48 hours recommendation for acute PD, or is uremia, hyperkalemia, fluid overload, metabolic acidosis, and to avoid the fluid ultrafiltration, we can increase by using Dextrose and shortening the cycle duration. So acute PD can be performed within in a center where capabilities and trained staff are available. You can start urgent PD. The relative simplicity and lower infrastructure requirement of PD make it less labor intensive and more cost effective than hemodialysis or hemofiltration. So thank you everyone for patient sharing. Thank you.
Thank you, Dr. Mohammad Ali Rumi, Assistant Professor from Sher Bangla Medical College, and Dr. Shakibuzzaman Arifin, Associate Professor from Kidney Foundation, for giving us knowledge about the biomarkers of AKI and how to use efficiently retinal dialysis in AKI.